All right, so with that, I think I'm going to turn it back to Erin and CDPH, and I think we're going to open it up for questions.
Perfect. Thank you, Jeff. Thank you, Karen and Jeff, for that wonderful presentation. We do have time for some questions, and I'd like to turn it now to my colleagues at the HAI program with CDPH. Shantala Anya, one of our infection preventionists, will be moderating the Q&A, and we'll also be joined by IP's Hillary Metcalf and Zenith Quadra. Thank you so much.
Thank you. Thank you for the great presentation, Jeff, Karen. There are a few questions which is on the chat, so I will a few of them I'm going to group together. But the first question to you, Karen, it's many of them, it's a common theme, many of them are having physicians. Physicians are routinely ordering for culture, UA culture, and then treating the patients, asymptomatic patients. Any recommendations from HSAG team on educating the physicians?
So this is probably when I would have those meetings offline. I'm not sure if we're talking about the regular physician or your medical director. If you have a medical director, maybe reach out to them. You can have reach out to CDPH, right, to provide some education to the physician as well. We've done meetings, group meetings with the physicians. Anything else, Jeff? At the top of my head, that's what, just, you know, and it depends on how we present the information too, using that assessment form and what we can identify when we do that reporting to the physician.
Jeff, any additional thoughts?
I'm sorry, nothing else to add from me.
Thank you, Jeff.
So Shantala, I can add one other additional strategy that I know has worked in at least in some acute hospitals. If there are a number of physicians that are providing treatment in your facility, if there is one that you can identify that is a champion for UTI prevention and appropriate treatment, work with that physician to basically speak with the other physicians about best practice. That works well too.
Thank you, Hillary. So one of the recommendations which we all talked about, you do have a policy in your facility on to manage both UTI as well as CARI prevention. So look at your policy, and then those policies should also include for when the staff supposed to collect for culture or UA, and when so that information should be included in your policy. And usually that policy is approved through your medical director, as Hillary and Karen mentioned. So making sure that policy, if you have it in your policy, and share that policy with your medical provider. So that's communication. And we are hearing a lot of these similar concern and issues in other buildings, and as we have done the visits. So hopefully with this training, so we'll have more support or more education for the physicians will be coming through. The next question for you is, I think many of them were related to the MD for UA appropriately ordering for a UA and the culture. Jeff, there is one question. Do we need to order UA after antibiotic treatment? If the resident has received an antibiotic, and do they need to do an UA to me as a clearing the infection?
Yeah, and this is Jeff. So yeah, so this is someone who's been treated for a UTI and then ordering again as sort of test to cure. That's correct?
Yes, it's kind of a test of cure.
Yeah, right. And this is where, yeah, I think we don't, or it's not recommended to, continue to test, over and over for that cure.
Thank you. So next question for you, Karen. Kathleen is asking, our lab is really pushing PCR urine panels as alternative to traditional culture. The report includes organism-sensitive reports and a level rating based on CT value. Are you aware of criteria assessment that is compatible with using PCR test in lieu of CFUs per ml measurement? Okay, so this is a more clinical question. So I'll pass it on to Karen, and then Hillary, Zenith, please give your input. Jeff, you too.
Yeah, I think I'm going to pass that one, Shantala, because I'm not familiar with the PCR.
Yes, Hillary, Zenith, if we need to get this clarification, we can bring it back during our office hour, which is the next week. So or if you have information, go ahead.
No, I think it would be best we can do some research on that and bring it back to the office hours. I'm not,
Yes.
at least I'm not familiar with that either.
So Kathleen will make sure we'll get you the answer for your question. So next question, Karen, it's for you. It's what we should do with the MDs that ordering upon admission from the hospital to skilled nursing facility.
Again, we're seeing this so frequently, where there's nothing to validate the reason that the resident is coming back on the antibiotic. There are no lab testing, and they just come back with antibiotics without a stop date too. So as we talked before, the communication, getting your medical director, if you have one involved, if they're coming back to the facility, reaching out, if it's the hospital, the case management department, because you should be getting a list of the medications before they come to your facility, and try to be a little bit proactive that way, instead of once they hit your door in on those antibiotics and then trying to get them DC'd.
Karen, I'm going to give a little bit of twist here. So many of the questions the IPs are asking these questions. So now, to bring it back, or train the trainer module. So now the staff, how do they educate? If you can give some examples, how the staff, the IPs can educate or train the frontline staff to make sure that there is no unnecessary order for UA or order for culture. So can you give some examples? I can start and then you can add. So for one of the example I would take is if the patient is altered mental status. So looking at the altered mental status, so you really need to see it just for the CNAs, for example. So they're looking at these residents very closely, looking at, so is it only one episode or multiple episodes? So you really need to look at before you call the physician to see whether, then the physician will be automatically will say, without even seeing the resident, they will order for the UA, or they'll order for the order for antibiotics. So that's more common theme I've seen, how you can educate your staff, train your staff on when to report or when to report to you, creating a steps. So report to you, and then see, and then or to report to the charge nurse, and then to assess before you call the physician. Karen, any additional thoughts?
Just one. This is where the UTI HSAG bundle tools should be helpful in moving towards that direction, helping to educate the staff ahead of time so they know what to look for, when to look for, using that assessment as a report sheet, and identifying ahead of time before we just pick up the phone and call and say altered mental status and nothing else.
Thank you, Karen. Jeff, can you go over, I think many of them are having trouble, because we all know that when they collect a urine specimen, if they leave it on the counter, or how do they, the storage versus, how they're handling the specimen can give them the false results that you have more than 100,000 microorganisms, but the resident is totally asymptomatic. Can you give some examples how the IPs and DSTs can train the staff on managing when they collect a specimen?
Yeah, I mean, I think it's just important that, they do that routine training and everyone knows, hey, okay, I collect it, and then here's my next step. It's to get it refrigerated immediately or get it to the lab. So yeah, I mean, I think it's just, it's a matter of, continuing to educate staff, doing that, weekly, monthly, whatever training interval that needs to happen, or new training, new hires, but making anyone who's sort of doing that, is trained on it.
Thank you so much, Jeff. I think it's almost we're close to our end of our presentation. I will, if we have not answered any of your questions, so we'll make sure that we will answer those questions during our office hour. Please make sure you register for the office hour. I will pass it on to Erin.